Any questions, I'd be happy to answer. Yes?
I have a question, a clarification on plaques, going back to one of your earlier stories, when the two patients come in when they're, losing their memory at age 65, patient A and patient B. So one comes in and you find the plaques, and patient A and patient B, you find no plaques. So patient A who have the plaques, question is, can you reverse the plaques, or is he a goner and forget it? And patient B, you find no plaques. Does that mean that you will not find the plaques, or 5 years down the line, he will also get plaques? And do you just concentrate your efforts on patient B, because then you can maybe prevent the plaques, but patient A is really a goner? So what?
Well, it's actually a great question, and I think I can answer it in two ways. One is, first of all, people, again, in clinical practice, different people have different, what we call the value of knowing, right? So I have memory problems. Okay, I'm not 29 years old. I know you don't believe that, but I have memory problems. But actually, I don't want to take the test. So the value of knowing for me is I don't want to know the test. But I'll give you one example. I had an 80-year-old man, literally a billionaire. He was a Jewish guy from Zimbabwe who had spent his entire life working, and he'd started businesses all over the world. And his wife brought him in because he had memory problems. And she was very concerned. He was on the board of all of his companies. He was playing a very active role. And she was concerned that he shouldn't be on the board and he should just slow down and, go off into the sunset. I examined him. He had memory problems. But I said to him, look, you travel too much, you drink too much, you don't exercise. I want you to do all these things. You have MCI. I said, you have MCI, but I don't know what you have. But let's do all these things and see what happens. They came back 6 months later, or 3 months later, and he said, he's better. And I said, wow, that's great. I mean, that's terrific. They said, but we still don't understand exactly what he has. And he still has some memory problems. Do you think he has Alzheimer's disease? And I said, well, there's only one way to find out. So we did the test, and it was negative. And it changed his life. And I have to tell you quite honestly that he came back another 3 months back from London to see me. And the first thing that his wife did was he says, Dr. Phil, I want to thank you, and here's a check. And she gave me a check for $100,000. So I think you have to think about this in clinical practice, what it means to people. And we're preparing for the future. Because when there are drugs that are disease-modifying drugs for Alzheimer's disease, and that's going to be in the next 5 years, and the first ones may be these anti-amyloid therapies, that test is going to be critical to who gets on therapy and who doesn't. And remember that 50% of people with a negative test, I can make them better. So this whole idea that cognitive aging, memory loss with 75 is inevitable is not true. And we can do a lot of positive things. So not everybody should get the test, but there are a lot of situations. Take PSA. Should I get a PSA? We have controversy about PSA every single day. What's the value of a PSA? And ultimately, the clinical guidelines are, it's the value of knowing. And individual people have to decide benefit and risk. Yes?
You spent a lot of time talking about estrogen. And I'm curious, with a woman who had a hysterectomy before menopause, how would that impact her likelihood? Even if she took, I'm not sure which one, but one of the hormone replacement therapies. My second part question is, soy has a lot of estrogen in it. What do you say about that?
So two great questions. Actually, I have a slide on your first question that I was going to show, but I don't have time. So the question is, does the age at surgical menopause, which is what you're talking about, hysterectomy and ovariectomy, right? So we're not just taking out the uterus, but both ovaries. And obviously it's taking out the ovaries, but the uterus tells us something about risks in terms of taking estrogen. There was a study published last month looking at age at surgical menopause and risk for dementia, okay? And the earlier that women got surgical menopause, the greater their risk for Alzheimer's disease and dementia and cognitive impairment as years went by. Now, what that tells us about drugs and biology is that estrogen exposure over a lifetime is very important for maintaining the brain. And I forgot your second question. Soy, right. Okay, so soy. So let's think about levels of evidence, okay? And actually, I think we might have a report on soy as a supplement in our website. There is evidence in biology and neurobiology for soy as an estrogen. There's some epidemiological evidence for estrogen. There's never really been any clinical trials. So I would say, the way I would answer your question is that it has some biological plausibility, but there's very little evidence for its efficacy, but it's safe. So for prevention, where people take things over a very long period of time, you not only want efficacy, but you want something that's safe and not that expensive. Soy is safe, it's not that expensive, but we have very little information on whether or not it really works. In the back.
My question is about the estrogen as well. If you have a family history of breast cancer and the breast cancer survivor had an estrogen receptive tumor and was put on tamoxifen and then Femara, and you also have a family history of Alzheimer's, which fire do you put out first?
Okay, no, it's a great question. And again, this is, there's two things. There's research and there's clinical practice. So the first thing physicians should do is do no harm. So in your patient, I would do no harm. I would never recommend estrogens. But you raised the issue of tamoxifen. And there actually have been studies of tamoxifen because it's a synthetic drug that in some ways mimics the effect of estrogen and in some ways blocks it. And it's a very complicated chemistry of tamoxifen. And you also mentioned another drug that women are given for breast cancer, which blocks the conversion of testosterone to estradiol, right? And so, there's been recent looks at whether the use of these drugs that are good for breast cancer are bad for your brain. So we're not going to stop women from taking drugs for breast cancer, but what we want to learn from those experiences is whether by doing that we're causing women to have cognitive impairment. And we do know now, we recognize this, that there is such a thing as chemo brain, and especially in women with breast cancer. So think about the biology of that. Women with breast cancer are going to get oophorectomies, they're going to get their ovaries taken out, they're going to have surgical menopause, and they're going to be put on drugs that block estrogen. So they're really getting walloped with estrogen deficiency. Well, it's good to, for life, it's good to prevent breast cancer. But what are the effects on the brain? And what might we be able to do about that to develop drugs to counteract the effects at the same time that we're trying to save the breast or the life of the person?
So to add to that, just to follow up, if you were diagnosed with breast cancer with a history of both these diseases and you're being treated by a breast surgeon, who do you go to for that second opinion for the Alzheimer's piece?
Well, let me say that breast cancer is also a disease of aging. We typically think of the dramatic cases of 35-year-olds like my mother who died at age 42 with breast cancer. But most breast cancer occurs in older women, and it increases with age, and it's a disease of aging. So your scenario is not that uncommon. I think that if you have an individual who has breast cancer, we're going to treat them by clinical guidelines and do everything we can to save their life. And we're not going to give them experimental therapy or withhold cancer therapy. We don't have enough information on the role of estrogen drugs or estrogen-like drugs in the treatment of Alzheimer's disease. Yes?
All right. Well, my question focuses on nutrition. Last year here, I never forgot that you sort of connected pathways to diabetes. Oh, thank you. The pathways to diabetes to potential early onset dementia. And so throughout the year, I've asked a lot of my friends whose parents or grandparents have had early dementia or Alzheimer's, do they have diabetes? And they have all said yes. So for me, it's a whole thing of like, is it the glucose? Now we're eating products with high fructose corn syrup, and how do you kind of connect this to real world nutrition and what we're eating every single day?
Right. So, well, let me just distinguish between nutrition and diabetes, right? So diabetes is a real disease, and it's type 2 diabetes, which is the most common type of diabetes, is actually defined by its insulin resistance, right? So the cells can't use insulin. Insulin is a hormone that brings glucose into cells so that cells can get energy. When cells don't get energy, they die. So people who actually have diabetes, I mean, there was just a report last month, again, diabetics have greater rates of brain shrinkage. They definitely have higher rates of Alzheimer's disease and cognitive impairment. So there's no doubt that there's a direct link between diabetes and cognitive impairment and Alzheimer's disease in late life. So what are the causes? What's the biology of that? Well, it's poor glucose utilization, it's low energy, it's insulin resistance, but it's also other things like people who have really high glucose. It messes up all the proteins, right? It's that hemoglobin A1C measure. Also, people that have hypoglycemic episodes, they're damaging their brain every time they have a hypoglycemic episode because the brain cells are dying. You know, you're losing 2 or 3 brain cells every time you have a hypoglycemic episode. So people that are strict control, in fact, today we recommend that people over the age of 75 or 80 don't have strict control because the risk of having too low a glucose is bad for your brain. So the relationship between diabetes and Alzheimer's disease and dementia is very clear. In terms of nutrition, the epidemiology is that eating a Mediterranean diet, avoiding obesity, and taking, making sure that you have the right vitamins on board. You're not vitamin deficient. You don't want to be B12 deficient. You don't want to be vitamin D deficient. You probably don't want to be deficient in other vitamins. But what you can do is you can go to your doctor and get these tests and find out if you are deficient. And if you are, then you want to supplement. The idea of whether or not supplements without being deficient really has any benefit is not quite clear yet. And I would say in terms of diet, just eat a healthy diet like a Mediterranean diet. And there are studies suggesting that eating a Mediterranean diet is not only good for your heart, but it's also good for your brain. So I would recommend a healthy diet. Okay. Yes, in the back.
And for people with mitochondrial disease, there's not much you can do, but they very much push antioxidants, and particularly coenzyme Q10. Do you think that supplementation with those kinds of antioxidants is useful for Alzheimer's prevention?
So the question is, the person has a son with mitochondrial disease, and yes, mitochondrial disease affects neurons. People with mitochondrial, it's genetic. And actually, we have a joint partnership with the Foundation for Mitochondrial Medicine, where we're doing joint funding exactly for the reasons that you're saying. We want to learn from what we're doing to develop better drugs to improve the mitochondria. And we're working with the Foundation for Mitochondrial Medicine to do that. And we're actually looking at novel new medications that can improve the mitochondrial function exactly for those reasons. And antioxidants may work because the mitochondria, that's where the oxidants are made. As a byproduct of the energy production, oxidants are made. And in people that have these mitochondrial deficits, they're not able to manage the oxidants that are made, and so they do need antioxidants. The problem is, again, bringing this back to new drugs. There has never been an antioxidant that has ever been shown to conclusively do anything in any disease. Okay? The levels of evidence that I talked about. So part of the reason in the brain is that most antioxidants, when you take them orally, they don't even get in the brain. And even when they get in the brain, they're not very effective in getting in cells and getting in the mitochondria and neutralizing those oxidants. So we're funding a study at the University of Kansas right now of a very novel antioxidant that's been shown to actually get into the mitochondria. And we're actually eagerly anticipating the results of a clinical trial of a very novel antioxidant that was repurposed from Parkinson's disease for the treatment of Alzheimer's disease to correct the antioxidant deficit that we see in Alzheimer's disease. I'm getting the signal. Thank you very much for your attention.